Good evening, everyone, and welcome to today's webcast, Treat to Target. My name is Jennifer Nguyen, and I will be your moderator for tonight's presentation. Before we get started, I would like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's speaker system by default. This means if you can hear music through your computer, you should be able to hear the presentation. If you would prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address as many as possible at the end. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as the voice for millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. In order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. For more information about these opportunities, log on to our website after today's program at www.psoriasis.org. Finally, I would like to thank our sponsors, Lilly, Novartis, and Valeant, for making tonight's presentation possible. Now, I would like to introduce our speaker, Dr. Abby S. Van Voorhees from the Eastern Virginia Medical School. As a professor and chair of dermatology, Dr. Van Voorhees specializes in caring for patients with psoriasis and eczema. She is actively involved in clinical research, particularly in issues related to the treatment of psoriasis, an immune-mediated disease affecting up to 8.3 million Americans. Prior to joining the Eastern Virginia Medical School in 2015, Dr. Van Voorhees was the Director of Psoriasis Services and Phototherapy Units at the University of Pennsylvania. Dr. Van Voorhees has published numerous peer-reviewed articles and has co-authored 3 books. Currently, Dr. Van Voorhees is medical editor of Dermatology World, the official magazine of the American Academy of Dermatology. She is also the first female chair of the National Psoriasis Foundation Medical Board and has been a member of the board since 2007. Welcome, Dr. Van Voorhees.
Thank you, and good evening, everybody. I'm speaking to you from Virginia, where we're already entered the evening hours. If you're coming online from elsewhere, then obviously it may be a different time for you. But I'm very happy to get the chance to speak with you tonight about Treat to Target. So let's talk about what our goals are for this session. The first thing we're going to talk about is how do you identify psoriasis severity? That's very important, especially as you as a patient might be trying to get a better understanding when you're talking with your provider about what kind of care you might be most appropriate. So that would be very, very helpful for everybody to be able to speak the same language. We're also going to speak about what Treat to Target exactly is. We're going to talk about appropriate treatment options based on disease severity. We're going to talk about how you might be able to prepare for your visits with your healthcare provider so that you can get the most out of them. And then we're going to talk about how to measure progress with personal treatment goals. So let's start by talking about what psoriasis is. Even if you have it, you may not feel like you understand it quite so completely. It's a chronic inflammatory disease that appears on the skin, and it's it's a complex genetic disease of the immune system, but we believe that there are environmental triggers, and some of those might be something like an infection. Other times it might be something like stress, and then of course there may be triggers that we don't completely understand. What happens in psoriasis is that the immune system malfunctions and makes the skin grow too quickly, and that creates a buildup of cells, and we often refer to that buildup as a plaque. One thing very importantly for everybody to understand is that this is not a contagious process. So why do people not like having psoriasis? I think mostly it comes down to what the symptoms generally are. The most common is that the skin can be quite itchy and sometimes painful. Also, it can be associated with a burning feeling or a stinging sensation. Patients sometimes will be very distraught by the fact that their skin will bleed, either because the plaques might crack or they may dry out. Other patients are very troubled by the scaling and flaking that accompanies their psoriasis. And last but certainly not least, that all of these discomforts sometimes cause people to have difficulty sleeping, and that lack of sleep is hugely problematic. So how do you address how severe your psoriasis is? Well, this isn't exactly the most exact, but many of us use it as a fairly good approximation as a way of trying to, figure out a patient's severity. We do what we call the palm surface area test. So what that means is if you look at your palm, if you take the palm and you add your first finger into it, as you see in this picture, that is equal to roughly 1% of your body surface area. Now, patients often wonder, what if their hands are small or their hands are large? Actually, it's the patient's hands that are in proportion to the rest of their body, so that's not a problem. Most people say that if you have up to 3%, three palms worth of psoriasis, that we consider that to be what we call mild psoriatic disease. Severe disease, most people agree, is 10% or more. And while it's a little controversial, most people think that in-between zone, between 3 and 10%, is considered more moderate disease. So, when I see patients in my office, sometimes they come in and they've not been treated for a long period of time. And you could say, well, why not? Why did they not seek care sooner? And I think sometimes that comes up because people are either worried that they won't be able to get access to various medications. Sometimes it's because they're worried that a treatment might have side effects that they might, not want to incur. And sometimes it's because they didn't really appreciate that how important it was to treat their psoriasis. We've learned in the last, say, 10 years that that the inflammation that is in the skin in psoriasis also affects other organs in the body, and that chronic inflammation in fact can lead to poor long-term health outcomes. So that more and more we're coming to understand that the undertreatment of psoriasis is problematic. What are the long-term effects? Well, we know that people who have psoriasis have a higher risk of having all of the diseases that are listed on this slide. They have a higher rate of developing depression. They have a higher rate of having problems with heart disease. High blood pressure is a not uncommon concurrent illness in the setting of psoriasis. People develop problems with elevated cholesterol. We see a higher frequency of inflammatory bowel disease, obesity, as well as psoriatic arthritis. So it's not that you absolutely will get any of these things if you have psoriasis, but that the risks are higher than what we would expect in the normal population. So what is Treat to Target You may have heard about it, not really understood what it is. Well, when you try to treat a disease to a target, what that means is that you're treating that disease to a defined and measurable level of improvement. In the National Psoriasis Foundation's Treat to Target effort, we involve patients, the NPF Medical Board, and other key opinion leaders in the field of dermatology, as well as practicing dermatologists. And we got everybody together to come up with these recommendations. And they were published in the Journal of the American Academy of Dermatology just this past fall. And these were the very first treatment targets in the United States for psoriasis. So the purpose of these targets were to set goals so that that we would develop a new standard of care for those who have psoriasis. Now, while these were the first treatment targets in the United States in dermatology, they are by no means the first treatment targets in the United States for other diseases. And many of you may be very aware of these targets. For example, blood pressure control. There have been targets, since the 60s and 70s, so that blood pressure readings now are expected to be quite a bit lower than they were, for example, in the 1940s. And the same is true for diabetes. We now, I'm sure many of you have had hemoglobin A1C levels drawn on you to see if they were normal or elevated. And if they're elevated, then often providers will talk with you about how that number might need to be tackled. And the goal of these treatment targets is to help patients and their providers to make treatment decisions, reduce disease burden, and improve the ultimate health outcome for that patient. So just a little bit about how we did it. First, we got together a group and we did a massive literature review so that we could be sure we knew what was in the literature and that we were completely up to date. And then we spoke to patients and we asked them what they'd like to see the target look like. And then we also surveyed practicing dermatologists as well, getting their input. And then we did what is a very prescribed scientific survey tool called the Delphi tool. And what this is a way of getting opinions to converge anonymously, so that people who have a stronger opinion or maybe have more prestige carry no more weight than somebody else. And basically, after 4 rounds of this Delphi tool, we were able to come to consensus. Sorry about that. So what were the targets? So essentially, the first thing is the target said that the preferred tool to use to measure that outcome should be the body surface area. And we asked questions of everybody. Should it be multiple tools? Should it be just one? Should it be a research tool? Should it be a tool that we used more commonly in a clinical setting? And as I said, the body surface area as a single tool came out as what was most preferred. When it came to the timing, basically the consensus was that that patients should be evaluated after a medication is started at 3 months. And what we were hoping to see, so our target, our goal, was to see a body surface area of less than 1%. Remember, that's your palm. So one palm or less is what we were hoping that patients would get to after that 3-month time period. But we were aware that some medications work a little faster, some a little slower. So we said, well, that's our goal, but it's acceptable if after 3 months people's body surface area had either was 3 or less percent, or if the body surface area had improved 75%. And the reason there's this and/or approach is that obviously when somebody's psoriasis is very extensive, getting to 1% or less might be a little bit harder than somebody whose disease, while still severe, but it might be very much less than that first example of the very severe patient. So we allowed that at 3 months, if you were 75% improved in your body surface area, then we considered that acceptable. The next point we decided was the point to evaluate patients again was at 6 months. And here you can see that the opinion of this group of key opinion leaders was that everybody should have, at 6 months, hit that target goal. They should be at 1% body surface area or less. So what aren't the targets? The treatment targets are not treatment recommendations. In fact, you could see in no place did we mention any particular medication or any particular therapy. And we made very clear when we published these treatment target goals that this kind of approach should never be used by insurers to deny any form of treatment. So what they do is they say to what degree and how quickly a patient and a provider should strive to get that patient clear or almost clear. And there was an understanding that for patients, each patient is unique, and therefore there is no one-size-fits-all treatment approach for a psoriasis patient. And that we needed to be sure that we had the entire range of available treatment options to offer that patient that might be sitting in front of us. We also acknowledged in our paper that there are certain situations where trying to get to these target goals might not be appropriate. Let's take an example of a woman who's maybe thinking about getting pregnant and really is uncomfortable with the idea of being on a therapy. Maybe somebody who's nursing. Obviously, other illnesses or health concerns might need to be factored into that decision making. And children, parents sometimes, might have feelings about how intensively they may want a child to be treated or not. But I think what we said very clearly in our paper was the goal here is that for a person who doesn't make that target is that they should be sure to have a conversation with their healthcare provider so that the appropriate goals for that individual would be set. So what are the targets? They should be the basis of the patient-provider discussion about all treatment options. And those options might be to continue the current treatment plan because of extenuating circumstances. It might mean to add another modality into the treatment regimen that the patient's already on. It could mean switching treatments or changing doses. So many choices could be considered, but what the targets are is they say, this is a patient that we should talk further about what options might exist and therefore how they might be able to achieve these targets if we consider them. Obviously, these treatment decisions need to be made according to the individual. The level of disease severity is very important. The type of psoriasis that person has and what body parts are involved is very important. Sometimes age is a large consideration. So I think those are all factors that need to be included in that ultimate decision making. So let's talk about a couple of the options for treatment, just to kind of familiarize you with it. One option are drugs that are often referred to as the biologics. And these are medications that are generally given either by injection or intravenously. There are oral treatments, which are medications that are taken by mouth. Phototherapy, sometimes people refer to it as light therapy, uses ultraviolet light. And then there are topicals that come in many forms in different bases and vehicles that can be used where they're applied directly to the skin. In general, for those with mild to moderate disease, we might be talking about using topicals, perhaps some phototherapy, or combination of things. Sometimes it's combinations of topicals, other times the mixture of topicals with light therapy. For those with more moderate or severe disease, we might be utilizing either the biologics, oral treatments, light therapy, or again, combinations of all of the above. And also, sometimes we're using topicals in these settings too. So the biologics are medications that target specific proteins in the immune system to reduce and clear the symptoms of psoriasis. There are three main categories named after exactly where they targeted the immune system. So currently on the market, there are tumor necrosis factor alpha inhibitors. There's interleukin 12/23 inhibitors, and there's interleukin 17A inhibitor. And this is a list of both the brand names and the generic names of the ones that are approved in the United States. You can see some are approved for just psoriasis, some are approved for just psoriatic arthritis, and some have both indications. When it comes to oral treatments, the oral treatments can work in a variety of different ways. Some act on the immune system, some act on specific cells in the immune system, and some act specifically on those skin cells. And here, again, we see a list of the oral treatments that are available in the United States. You can see that the first two are only generic at this point because they're older medications, while the last two, we've included their brand names as well. Here again, you can see that some of them work only in psoriasis, whereas others work on both the on psoriasis and psoriatic arthritis. Phototherapy uses UV light to treat psoriasis. And there are three main types currently that are being used in the United States. UVB, which can either be in a narrow band form or a broadband form, is usually administered in a full body unit, although occasionally small units are utilized for people's hands and feet. Laser UVB uses a single wavelength in the narrowband region of the UVB spectrum, harnessed in a laser device. PUVA is a mixture of UVA wavelength light and psoralen, which is a light sensitizing medication that makes us humans respond to UVA in a way that we don't normally if we were not to use the psoralen medication. And then topicals, as I said, come in many forms and strengths. You can get hydrocortisone over the counter, which is the weakest strength, but then they come in many strengths by prescription. And then they come, as I alluded to earlier, they come in many different kinds of vehicles, such as some come in liquids, some come in creams, some come in ointments. So, and that often facilitates their use in various body parts. In addition to topical steroids, there are vitamin A derivatives that can be used topically, vitamin D derivatives, and as well as some off-label options. So when you're going to have an appointment, it really helps, especially if you'd like to take an active role, if you prepare for it in advance. I think shared decision-making occurs when both you and your provider work together to make a treatment decision that feels right to you. In order to share in that decision-making, though, it's really helpful if you understand your disease and your options as you go in, or at least understand it to a degree so that you can be educated further during the treatment visit. I think what that allows for is for trust to develop, support, and most importantly, clear communication. So these are some of the questions I think are important that you want to be asking when you go to to see your provider. You sure want to know how severe they think your psoriasis is and what options for treatment might be appropriate for you. some people want to know how long these treatments have been used for either for psoriasis or psoriatic arthritis. Some people might be a little less comfortable with a new modality and might prefer something older. Conversely, others sometimes want what's the newest, the latest, and the greatest. So, but understanding that, I think, is certainly something you might want to learn about. I think many people would want to think about what percentage of people will improve if they use that possible treatment. And very importantly, how quickly can I expect that improvement to occur? Nothing is as disappointing as seeing your skin not get better after a day or two, but that disappointment could have been prevented if you had understood that it was going to take 3 months, for example, for that medication to really kick in. Certainly, I think everybody wants to know what the potential benefits and risks of the medication, and as well as what the most common side effects might be. I think understanding how often you need to have blood work, if so, and things like do they need to be does this blood work need to be fasting? I think it's very important that you think about, if you don't like the sound of a treatment, what your other options and alternatives might be, since that's something you certainly want to have a conversation with your provider. So I think what's important, the important considerations in general, is to understand how severe is your disease. I think most people can understand that if their disease is on the very mild end, then the treatments that might be considered will be very different than if your disease is on the severe end. You want to understand what kind of psoriasis you have and where it affects. For example, involvement on the palms and soles might not be that extensive, but it might make it difficult to walk or open a jar or do things, making the severity, even though it's not such a large amount of body surface area, it might make the severity of that disease quite great. Also, the age of, your age. Are you, a child? Are you an adult? Where are you in your life? That certainly is an important consideration. Other factors to consider is your insurance coverage and what your out-of-pocket costs might be, what other medical conditions you have, what other medications you might be taking. Of course, you're going to be wanting to consider how you like the sound of the potential side effects and the long-term risks of any modality that you're thinking about, as well as how it gets administered to your body. If you're somebody who couldn't imagine taking an injection, then the method of delivery is very important that you understand. Because I think when people like and feel comfortable with the modality, then they're much more likely to adhere to their treatment. So just because you're at first blush you think that you might not like something, sometimes there's ways to address your concern, and often I find patients grow to be very comfortable. So I was saying earlier about maybe you might be a little uncomfortable with the idea of an injection. But in fact, I find sometimes that if your healthcare provider trains you in how to do it well, maybe you find that's actually not such a problematic thing. I've had patients worry that oral medications, they might forget to take them. Well, those of us who are tech savvy, I've had patients have their cell phone call them, so that they can remember to take their pills. Phototherapy, people sometimes worry, could be time-consuming and costly. Well, that may turn out to be an issue for you, and if it does, perhaps you might want to speak with your healthcare provider about whether doing home phototherapy might be a good option for you. And when it comes to topicals, sometimes people worry that the mess, or that applying them will be inconvenient. And I think once people get into the flow and have a daily routine, then it often helps with mitigating that concern. And it goes without saying that you want to understand what's the benefit of treating and what's the risk of not treating. So, for example, the benefit of treating might be that your symptoms feel better and your skin will clear. But, of course, then there's the risk that the treatment you're taking might cause a side effect. There may be a benefit that there's reduced inflammation throughout your body, but again, there may be some risk from the medication. So I think it's very important to have a conversation with your provider about the benefits and risks so that you understand them and make choices that make sense to you. And certainly, as we talk about in our Treat to Target guidelines, we want you to assess your progress. It's very important that people have regular appointments with their provider at 3 months and 6 months after starting treatment so that we can be sure that you're getting the response that we're hoping you are. Nothing is more frustrating than having a patient take a medication for years and have it never having worked. Really, that's something that is very frustrating for both the patient and the provider. You want to document your symptoms. I know patients will sometimes write down in a journal so that they can keep track of how their skin felt. Sometimes you think you'll remember, but 3 months and 6 months are pretty long periods of time, and it's helpful to jot a few notes along the way, so that way when you go to your provider, you're able to mention the fact that whether you had flares at different times or whether you had been well controlled the entire time period. What I found is that some patients these days have found it really helpful to take pictures and just store them on their cell phone, and then they bring them in at their visit so that I can actually see a little bit what their skin was looking like, during the ensuing months. I think you and your healthcare provider will determine how to adequately assess your treatment plan and decide whether staying on the right plan, on the same plan for a longer period of time, whether that's right for you, whether to make changes, whether to increase the dose. All of those kinds of things are what you and your provider are going to want to put your heads together and assess when you show up for your next appointment. So here's an example of using treatment targets. So in our example, our patient John Smith is a 54-year-old with a 25-year history of psoriasis. And he previously tried 2 medications, Humira and Enbrel, with some effectiveness, but over time that those benefits waned. And he came into the office this time complaining of severe plaque psoriasis on the scalp, the trunk, the arms, and the legs. So he was started on another medication, Cosentyx, and at 3 months after starting the new medication, he had a BSA of 1%. So you can see in this situation, the provider's response is that this person should continue on his medication at the same dose and just follow up at 6 months, since he achieved that treatment goal. Here's another example. Mary Johnson is the patient, and she's 35 years old, and she previously was not treating with any treatment options. She had moderate severe plaque psoriasis, as well as was very upset about how her skin appeared. So she was begun on Otezla, one of the oral medications, and at 3 months after starting it, she had a 50% improvement of her body surface area. So not quite making that treatment target. Oh, sorry, I went the wrong way. I apologize for that. So the plan was that she should continue the Otezla and use a topical steroid for some of her stubborn patches. And at 6 months after starting her treatment, her BSA was also less than 1%, again, making her target. So what does the future hold? We hope that patients and providers will use our Treat to Target as a way of achieving goals. We're going to be measuring the impact of Treat to Target so that we can see what works and what does not for that individual patient. And we want to upgrade these targets as new ways of measuring the impact of the disease of psoriasis and its severity evolve. So that I expect over time, same like our blood pressure targets have steadily changed over the last decades, I expect our psoriasis targets will need to be updated again and again as well. And that may also be the case as new treatments emerge from our drug pipeline. So that's something we have to be open to too. So what do I want you to remember? I want you to remember that no treatment is excluded by Treat to Target. All accessible treatment options, we believe, should be available and considered when making a treatment decision for that individual patient. Because after all, psoriasis patients are each unique, and therefore everybody's special circumstances, their unique situation, the type of psoriasis they have, the location affected, all of that has to be factored into the decision of what would give them their best outcome. Of course, patients and providers have to discuss the risks and the benefits. I think here that patient-provider dialogue is key to making that ultimate decision. And then that has to be factored in how to make that preferred option allow that individual patient to get to our target goals. I think we want to stress also that we want patients to achieve their best possible outcomes so that we can get people to have as little systemic inflammation as possible. This is the first step of an ongoing effort, I expect, that will continue to be refined over time. I now open the floor to questions that people might have.
Great. Thank you so much, Dr. Van Voorhees. So now we will move on into the Q&A portion of this webcast. So our first question here is, can my primary care physician treat my psoriasis, or does it require a specialist?
So I think that's a very individual question. It depends, first of all, on the patient and the kind of psoriasis they have and the amount of psoriasis that they have. And it also depends on the person's primary care doctor and how comfortable they are with the various treatments of psoriasis. In general, though, and this is of course just a generality, in general, primary care doctors are pretty comfortable treating more limited psoriasis. I'd call that the mild type of psoriasis that we talked about earlier. They often are comfortable prescribing topical therapies and trying to get that patient started. In my experience, I found primary care doctors a little less comfortable with using either the oral therapies or the biologic therapies for those who have more recalcitrant or more extensive psoriasis. So I find in general that for people with moderate to severe psoriasis, that generally they're better served in the hands of a dermatologist.
Great, thank you. Next question, how many years can you safely be on a certain biologic? When is it a good time to try another one?
Well, to your caller, I would say this. No one has studied exactly what the longest amount of time you can be on a medication is. But my rule of thumb is if it's not broke, don't fix it. So when you're on a medication that's working well for you, if you're making the treatment target, then I would tell you not to switch at all. Because currently we don't have good tools for predicting which medication someone's going to respond to or not. And it would be truly a shame if you were on a medication that was working well and you stopped it arbitrarily and then found out that the next medication that you tried didn't work for you at all. So I think I really encourage my patients, if something is working, to just stay with it, because we, assuming that they're making the appropriate targets.
Great, thank you. Next question, what is the best way to manage scalp psoriasis?
Well, there are many ways to manage scalp psoriasis, and scalp psoriasis is the bane of many people's existence who have psoriasis. So sometimes when it's more limited, we use topical medications, and they can be sometimes in liquid form, ointment form, shampoo form, foams. There are many, many different vehicles that they come in. And for someone who has more limited disease, that can be all that's necessary. When scalp psoriasis is more persistent or more extensive, then sometimes we use the UVB laser modality that we talked about earlier. And sometimes we use oral medications and even ultimately biologic medications, depending on how severe it is. So the extent of the disease, whether the person has psoriasis anyplace else. Sometimes we see psoriatic arthritis occurring in people who have scalp psoriasis. So, does that person also have current psoriatic arthritis is a very important factor. But as a rule of thumb, we use topicals, and when they don't work, we turn to more intensive modalities to try to see if we can't get it under control.
Great, thank you. And similarly, what is the best way to treat palmoplantar pustular psoriasis?
Yeah, when psoriasis involves the palms and the soles, you could imagine it's totally dastardly. And as I said earlier in my presentation, even though it's not a very large amount of the body surface, it can make it very difficult for people to walk or work because they can't write, and people can be truly miserable with that variant of psoriasis. So in general, while we sometimes use topical medications such as topical steroids in that setting, and sometimes we're fortunate and that will be effective. More commonly, because of the severe symptoms that often occur, accompany this variant of psoriasis, more commonly we wind up turning to either ultraviolet light treatments or systemic medications. And the systemic medications can be some of the oral medications, but they also can be some of the biologic medications. So it's really that the severity of the symptoms that sometimes drive us to more intensive treatments earlier than, we might have had that same amount of psoriasis been on somebody's, say, thigh. So that often is a big factor in that variant of psoriasis.
Great, thank you. Another question, my psoriasis has progressed to where I am considering a biologic. What is the safest one? Can you comment on new medications such as Taltz and Cosentyx that seem as though they might be safer?
Well, I say to my patients that the safest medication is the one that you as the individual patient tolerates well. And so I think if you're thinking about a biologic because your disease is severe, that has to be, then the risks of a medication get interpreted through that lens. So in other words, I don't think any of us, for somebody who had, a dime-sized amount of psoriasis as their entire psoriasis on their, on their elbow, I don't think any of us would be thinking about putting a patient on a medication, be it an oral medication or a biologic medication. But I think all the biologic medications in general are very well tolerated, and most of my patients do extremely well with them. With all of them, we worry about the risk of infection. That's probably the main risk. There are lots of others that are, that show up in that package insert that occur very, very uncommonly. But the main risk that I think patients need to be thinking about is the risk of infection. And even that in our psoriasis patients tends to be, we believe, it tends to be fairly small and may in fact be smaller than some of the other diseases that these same medications are utilized for. For example, they're also used in rheumatoid arthritis, and it may be that rheumatoid arthritis patients have a little more risk than patients who have just psoriasis. So I think all of these medications are quite safe. They have slightly different safety risks. So for example, you know, the risk of a medication like Taltz or Cosentyx, there may be a little bit more of a risk of an infection called Candida. And there may be a little bit more risk for, in the setting of somebody who has either previously been diagnosed with inflammatory bowel disease or maybe has a strong family history of inflammatory bowel disease. On the opposite side of the equation, the TNF inhibitors may have a little more risk in the setting of someone who has a history of bad heart disease and has congestive heart failure. So I think the risks of each of these medications have to really be interpreted in terms of you as the unique individual person that you are. And exactly what other medical problems you may or may not have is critical for your provider to really be thinking through as they make choices about what medication is truly the safest in your unique situation.
Great, thank you. Next question. Does inverse psoriasis require a different protocol than plaque psoriasis?
Well, let me tell you a little bit what inverse psoriasis is. It's a type of psoriasis that tends to occur in women under their breasts. In anybody, it could occur in the armpit. It can occur under belly folds. It can occur in the folds of the legs, and it also could involve the genital area. And very commonly, we also see that involve the scalp. So I think that's where it tends to be present. As a result of that, sometimes we have to be a little bit more careful because those areas tend to have a little thinner skin and be a little more delicate. So for just the easiest example might be to say, if I had a plaque of psoriasis on the knee, I'd have a little less worry about using a very strong topical steroid to try to help that inflammation in that plaque settle down. That same size spot in the armpit, as an example, I'd have to be a little more cautious about the strength of that topical steroid because the skin is a little more delicate. So sometimes we have to make choices in terms of which therapy to use based on whether it's plaque psoriasis or whether it's inverse psoriasis. And conversely, inverse psoriasis in general, as a stereotype, tends to respond a little bit more readily to topical agents. And so very commonly we're able to control it with those. But occasionally it can be very persnickety, and in those situations systemic therapies, be they oral or biologic, are appropriate. So sometimes we're using the very same modalities for inverse psoriasis that we were talking about when we think about plaque psoriasis.
Great, thank you. Next question, will reducing the amount of body surface area affected also reduce the chances of developing comorbidities?
Yeah, that's a great question. I don't think we know the answer for sure yet, but people are starting to look at it. The question really is, if I treat somebody with a systemic medication, can I reduce the systemic inflammation throughout their body, not just in their skin? And will that lower their risk, for example, of developing heart disease? Or will it prevent them from going on to develop psoriatic arthritis as just two very important examples? So these questions are being studied right now, but but we don't actually have the answer. There's some very preliminary data in the rheumatoid arthritis literature that it may, in fact, allow for the reduction of inflammation and therefore a reduction of comorbidities. But we don't know the answer yet in our, from our psoriasis patients.
Great, thank you. And I think we have time for one more question. If a biologic has worked for a while and then loses its effectiveness, is it possible to go back on it several years later and find that it works again?
Yeah, that's another good question, and one we need more data on. I think in general, the answer to the caller is that yes, sometimes it does seem like a respite allows for resetting of the clock, so to speak, and allows that medication once again to have regained effectiveness. Other times, however, that's not the case, and that once that person has lost effectiveness from that drug, it's really best to switch to an alternate agent. So I think there again, it depends on what the person's other medical situations are and how necessary it is to revisit that same medication. So I think that's a decision that we need to know more about. So we need science to answer that question a little bit more thoroughly and see, maybe down the line there'll be tests that we can utilize that will tell if people have regained that ability to respond to that medication. I hope that will be the case.
Great, thank you. And I think we'll try to squeeze in one last question here. Do you see any promising research on identifying environmental factors involved with psoriasis?
I sure do. There's all sorts of experimental work right now on what's called the human biome, which are bacteria that we all have that live on our skin that are completely normal, part of being human. And they live on our skin and they live in our gut, and there is some exciting work being done right now trying to understand if their balance is not in the expected balance, whether that may be a trigger for psoriasis. So I think we're poised to learn a lot more about this disease in the coming years, and so I think we'll be able to have different conversations 5 and 10 years from now.
Great. Thank you so much, Dr. Van Voorhees, and thank you so much for sharing your expertise with us.
Oh, you are very welcome.
Oh, thanks. All right, and if you have any other questions, please contact our Patient Navigation Center by phone, email, live chat, or Skype. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. Again, thank you to our sponsors, and finally, I just wanted to mention that a recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archive by visiting www.psoriasis.org/webcast. Thank you to everyone for joining us tonight, and have a lovely evening.